I hope that everybody can see the screen. And so today's session is going to be on HPB surgery. And HPB surgery involves everything, from the liver, the pancreas, and the gallbladder. And these are very important parts of the surgery exam. They form a huge chunk of your surgery exams, both in 5th year as well as in 6th year. And the first thing is that I would like to just introduce myself. So my name is Dr. Aparajeya Shanker. I'm a recent graduate from MU Pleven. And the reason why I'm doing this course is because I have identified certain areas which all of you need to focus on. And I would like to take this opportunity to formally welcome you to the Surgery and Essential Review course. So before we begin, this is just a small note. This is an ongoing project, and we have other lectures coming up very soon, including one next week, and that will be on colorectal and stomach surgery. And in the week after that, we will be talking about thyroid and breast masses. And the content of the surgery course is limited only to essential topics. We are going to take this opportunity to, learn the basics as well as learn the, the more important stuff that we need. Right. So with that said, I'm just going to go on to our first overview of what we're going to cover today. And this session is going to be short. I'm going to try to keep this within an hour or an hour and 20 minutes at the most. And towards the end of the lecture is when I'll give you the feedback form. Please fill out the feedback form, and that's when you'll get the presentation delivered to you directly for download. And the feedback form is also the way to get your certificates for attending this full course, right? So with that said, let's take a look at the overview of the HPB section. We are going to first begin with portal hypertension. Then we are going to talk about hydrated disease and mechanical jaundice. And then we'll move on to the gallbladder diseases. And finally, we will end with pancreas. And we are going to try to make this as interesting as possible. So the first section today is the liver, right? And in the liver, the first thing that I think we should remember is the liver's blood supply, drainage, and the path of blood through the liver. And this is important because you see most liver diseases have something to do with the blood supply and the drainage. And the first thing you need to know about blood supply is that the dominant blood supply of the liver is not the hepatic artery, it's the hepatic portal vein. And the hepatic portal vein is fed by the superior mesenteric vein and the splenic vein. So the superior mesenteric vein and the splenic vein come together and they form the hepatic portal vein. And 25% of the blood volume that goes through the liver comes from the hepatic artery. And the drainage is done by the hepatic veins, which drain into the inferior vena cava. But when you look at this in greater detail and you try to look at the path of blood through the liver, you can see what the importance of the portal circulation is. Now, portal circulation is, the portal vein, which, is formed, which enters into the liver. The portal vein then divides into central veins, which are present in every lobule of the liver. And all of these lobules come together to form the two right and left hepatic veins. And it is the hepatic veins that connect to the inferior vena cava. So this section here is the portal circulation. And a vast majority of diseases actually affect this part of the liver circulation, which is the portal circulation, right? And when we discuss this in greater detail, we'll be able to understand this in portal hypertension itself. So portal hypertension is when there is an elevated portal vein pressure. So when the pressure goes above 10 millimeters per Hg, when it elevates beyond that is when you call this portal hypertension, right? And portal hypertension can be caused by a lot of different things. The most important is cirrhosis and schistomiasis. Now, hepatitis, for example, also causes portal hypertension, but this is at a very late stage. And one important disease here is called Budd-Chiari syndrome. So Budd-Chiari syndrome is when you have venous emboli in the hepatic veins themselves, so here. And what happens when you have portal hypertension is that there is a lot of pressure in the portal vein, and because of this accumulated high levels of pressure, there is actually backflow into the feeding veins, which are the splenic vein and the superior mesenteric vein. So remember this, when you are talking about portal hypertension, the blood is not flowing forward as it should. It's getting stopped here because there's a lot of pressure. And when there's a lot of pressure here because of either a blockage, is the case in Budd-Chiari syndrome, or in cirrhosis where the central veins are congested themselves, this causes a buildup of blood in the feeding veins of the portal vein and any other vein that feeds into it. So the most important thing is that the symptoms of the patient will always be something like splenomegaly, melena, hematemesis, and hematochezia, because the blood is actually going from the veins into the larger intestine. And once it enters the large intestine, the blood will be present within the stool that is forming, and then it comes out within the stool as well. But most importantly, this is the part that you will be asked in the oral section of your interview. Regardless, if you get any liver question, then this is particularly true for 5th years and 6th years, the professors will ask you what is the most common complication of portal hypertension. And you have to say esophageal varices. Because most patients who come to you with esophageal varices will come to you because they have portal hypertension. And this is the link that you always must say. And the veins that are involved in the portal, in esophageal varices, are the coronary vein, which is the left gastric vein, which actually feeds into the esophageal plexuses, which you can see in this image here. And the problem here is that most of the time, the patient presents with vomiting and a lot of blood in their vomit, which is, hematemesis. And this is because there's a lot of esophageal variceal bleeding, which is a very dangerous complication, and it needs to be dealt with immediately. Now, the other common things that you see, which you've studied in propedeutics of surgery and internal medicine, is caput medusae, splenomegaly, and hemorrhoids. Now, caput medusae is also caused by portal hypertension. So if you see a patient who has caput medusae, immediately think that he or she may have portal hypertension, right? And when you look at it within the context of a long-standing liver disease like cirrhosis, then you should raise the suspicion that this patient has portal hypertension and may have esophageal varices as well as caput medusae. Now, in terms of management, when you're going to define this topic, always remember that you need to divide it into management. It is not always important to know the in-depth idea of just the pathophysiology, because pathophysiology is easy. The more difficult thing is how you're going to manage such a patient. And we have the first line of investigation, which is upper GI endoscopy. Now, this investigation is a very important one. Every time there is a practical exam, in most of the exam sessions, there will always be a patient who has portal hypertension or hematemesis or whatever. And you will be asked to define or suggest what you think is the best treatment option or the best initial investigation, and it will always be the upper GI endoscopy. And the reason why it is important is because when you do GI endoscopy, you get to see the esophagus and see if there are varices or there is bleeding. And if there is bleeding, you can deal with it immediately just by using the endoscope. So in this image here on the right, you see that this is a upper GI endoscope. And this upper GI endoscope allows you to visualize the esophagus, especially the distal esophagus, look at the veins and if there are any varices, and then to deal with them. So we usually divide management into pharmacological and interventional management, right? So pharmacological management generally occurs when you take somatostatin or IV vasopressin, which are very strong vasoconstrictors, and they are given so that these varices are sort of compressed quickly, right? But the issue is that both vasopressin and somatostatin are very powerful. And what I mean by powerful is that they act across the body. So somatostatin and vasopressin can also cause vasoconstriction in the heart. So in order to counteract that, we also give the patient nitroglycerin, right? And this is combined with octreotide, which is sort of like a gastroprotective drug. It helps to it serves a lot of different functions, but for us, it allows us to eventually enter the endoscope as well, so that there's no further inflammation of this area because you're inserting a foreign object here. In terms of the interventional methods we have at our disposal, as you can see, emergency endoscopic sclerotherapy is one of them, but you use sclerotherapy only if there is no variceal bleeding. If you think there is variceal bleeding or you can see variceal bleeding, then in that case, you need to just use something called endoscopic band ligation. And the band ligation is when you tie off bands here for very swollen varices so that their blood supply is cut off across the esophageal wall. But in most cases, when the patient doesn't necessarily have very heavy bleeding, there's no hemorrhage, you insert this thing called the Sengstaken-Blakemore tube. And you need to mention this to the professor that, yes, one of the treatment options that I would use is a Sengstaken-Blakemore tube. And this Sengstaken-Blakemore tube what it does is that it's like a balloon, and it causes balloon tamponade. And its most important function here is to actually create a tamponade in the esophageal region and one in the gastric region. And you inflate the balloon using saline, and this presses up against these varices. And once it presses against these varices, what happens is that you can stop or tamponate the bleeding, and you can push this blood back into the esophageal plexus. Now, finally, we have operative techniques as well. There are two operative techniques. One is called TIPS, which is transjugular intrahepatic portal shunt. And the next option we have is surgical shunting. But before we go into the depths of operative treatment, we have to look at whether the patient is fit for treatment or not. So for most liver diseases, especially when it comes to portal hypertension in specific, we use something called the CTP score. Now, I'm not going to go into the full detail here, but you should study and know this, because this is used for staging and seeing whether a patient is fit for surgery or not. And this goes for a wide variety of liver disease, including hepatitis, severe hepatitis, cirrhosis, whatever. And you can see here that the main idea is that we try to categorize the patient according to CTP classes. So class A patients can undergo major surgery, such as surgical shunting or whatever, whereas class B and class C patients show very advanced liver failure, or they are in such a situation that the liver failure is in such a stage that you can only do a liver transplantation, not even a liver resection, right? So once you stage the patient, when they come into the department and you do your clinical exam and you look at all the blood reports, you can stage the patient according to three ways. Either it's a class A patient, class B patient, class C patient, and then you decide what kind of surgery you need to do. So if there's a class A patient, then yes, you can just you can immediately go for a full-fledged shunt, and we'll discuss shunts in the next slide. But for class B and class C patients, you have to just give them a Sangstark-Blakemore tube, stop the bleeding, then reassess, right? Let's go into the high yield parts of portal hypertension. Look, so portal hypertension, in general, the pressure has to be above 10 millimeters, right? Normal pressure is between 5 to 10 for most normal people. And you have varices. The variceal formation occurs at 10 millimeters, but variceal bleeding occurs when it's over 12 millimeters, right? And when you look at the etiology, yes, we can divide it into pre-sinusoidal, sinusoidal, and post-sinusoidal. But I want you to look at the cirrhosis part again. Patients who have HBV, HCV, and excessive alcohol use usually present with portal hypertension when there is advanced cirrhosis present. And when there is cirrhosis in the patient, you will have you will have the situation where their portal hypertension is extremely high, and you might mostly see those patients with active variceal bleeding. And when you have active variceal bleeding, you need to stop the bleeding first, right? Now, in esophageal varices themselves, the blood supply is largely through the anterior branch of the left gastric vein, right? And in terms of therapeutics, remember, you need to mention somatostatin, vasopressin, and octreotide, which is all involved in the initial management of bleeding before you can do any major operative cases. Now the operative section comes, and this is when we actually do the main surgical management. So the first one is called transjugular intrahepatic portosystemic shunt, also called TIPS. Now, the purpose of TIPS or any kind of shunting is that you are trying to divert the blood flow from the portal vein and try to force it to enter the systemic circulation, which means you're trying to move it from the portal vein directly into the inferior vena cava by bypassing the liver in every way possible, right? So TIPS is the easiest way to do this, because you don't need to open the patient, you don't need to do preoperative planning. You can just sort of insert this shunt, and you can shunt away all of the blood from the portal vein, and you can just direct it into the IVC or in the right hepatic vein. Either one is fine, but for the purposes of this one, for this talk, we're going to stick to just the right hepatic vein. What happens here is that if you notice that the shunt directly connects the portal vein to the right hepatic vein, and it bypasses this entire portal system. And this bypass is very important because there's just too much pressure, and everything that's behind this, the esophageal varices, the splenic vein, the splenorenal vein, the superior mesenteric vein, all of this is congested and it needs to be drained. And the best way to drain it is by just allowing the portal flow to connect directly into the systemic circulation. And there are a few indications and contraindications. The primary indication is that this is used only for secondary prevention of hemorrhage, right? That means the patient has already come once for bleeding and you've dealt with the bleeding and now you want to stop the bleeding from recurring again. You don't do tips while the patient is bleeding. And this is an important part because the professors are going to ask you, the patient is bleeding with a severe esophageal variceal bleeding. Will you perform a TIPS or not? And your answer has to be no, we will not perform a TIPS while the patient is actually bleeding because we need to stop the bleeding, stabilize the patient, get the hemoglobin up, and only then can we do this, right? Now, the contraindication, like I said, is primary prevention. Like you don't use it at all when the patient is actually bleeding from their varices, right? And you do the surveillance through something called Doppler duplex ultrasonography, which allows you to measure the flow of blood via the shunt itself. And once that is used for measuring something called the patency of the shunt, which basically means that you are trying to assess whether the shunt is successful or not. Now, you have portosystemic shunts. Now, we are not going to go into the very depth of portosystemic shunts, but portosystemic shunts do the same thing, except that instead of using like a material like PTFE, for example, or a metal shunt, we just directly dissect the splenorenal vein or the supramesenteric vein or the portal vein itself, and then we just redirect it and connect it directly into the inferior vena cava. Now, the point here is that we generally divide portosystemic shunts into three types. You have non-selective, which diverts all the blood flow that is coming by the portal vein directly into the IVC. Then you have selective ones that are used only to decompress certain sections. So, for example, the gastroesophageal and splenic venous supply. Those things, like in this picture here, this is a gastroesophageal plus a splenic venous supply shunt. And you have basically dissected everything, removed and isolated the portal system or the portal vein, and you connect all of these veins just directly into the IVC, right? And with this, you have you are only sort of selecting these areas. For a total non-selective one, you would remove literally everything, including the SMV and all that, and any collateral flow. And those are very complex surgeries, and many patients will not survive them. So most of the time, we try to use selective shunts, and partial shunts are a bit like TIPS, except when TIPS is using a actual like a shunt material or a stent. In partial selection, what happens is that you just cut the portal vein directly and just insert it here into the IVC without inserting anything else, right? And it only diverts portal venous flow, but it leaves the rest of the collateral flow and hepatic artery flow and everything going as it is. So with that said, we have just sort of completed liver portal hypertension, and we're going to go into hydatid disease. Now, if at this stage you have any questions, please text me in the chat. Only I'll be seeing your questions. So, for example, there is one question here: is Blakemore tube the first line of treatment? Yes, when you have a actively bleeding patient, in that case, you use the Blakemore tube to stop the bleeding and stabilize the patient, right? And that is if you don't have access to an endoscopy suite. Now, for example, if you want to use, you have two conditions here, right? So the first condition is that the patient has very high portal hypertension, but is not actively bleeding per se. So if they're not actively bleeding, use the Blakemore tube. But if they're actively bleeding, and bleeding heavily, and they're in shock, like circulatory system collapse, then in that case, the Blakemore tube is only used if you don't have access to an endoscopist and you don't have access to an upper GI surgeon who can do it immediately. So, for example, if you are the FY2 in the area or the FY1 dealing with this patient, insert the Blakemore tube because that is better than nothing, right? Now, the other question is, which situation do we use each shunt for? The thing is that the direct indication is portal hypertension. The only determining factor in choosing which kind of shunt you're going to use is whether the other veins are congested or not, right? So if you have heavy congestion in the upper, in the gastroesophageal and splenic venous supplies, then you just use a selective shunt because you only want to decompress those. And you also have to take into account the patient's CTP status, right? So for example, if the patient is CTP status B, that means that they have a lot of all the veins that are actually supposed to feed into the portal system are completely congested. Then in that case, no, you can't really do much. You can insert this TIPS shunt and hope for the best, right? Now, that is the only thing we can do. Here, you would say if a patient has esophageal varices isn't an upper GI endoscopy contraindicated. No, because if you have varices, you have to do an upper GI endoscopy to view the varices, to stage the varices, and to see if there's active bleeding. And if there's bleeding, you just apply bands, or you try to ablate and try to stop the bleeding first, right? That is the use of the upper GI endoscope. That is not a contraindication for. In fact, if you suspect a patient has varices, use the endoscope, right? What is the risk of causing bleeding through the use of endoscopy? And the following question is, can it not cause bleeding? Look, if a patient it entirely depends on how good the endoscopist is. Now, of course, if the endoscopist has no skill whatsoever, and which is going to be very, very rare, then in that case, anything could be a risk, right? There is a risk of very small amount of risk for causing bleeding, and it's probably less than 3%, right? The issue is that when you're inserting an endoscope as well, the first thing that is going is the camera, not the instrumentation. And the thing is that if I go back to this picture here, you can see that the main way of using the endoscope is that you're not trying to hit the walls. And you have to be very careful with that. And if, for example, you can't pass the endoscope to a certain level, then you say that this is a very severe varices, which will require you to use a shunt first and then try to use that to sort of reduce this inflammation or this congestion. The primary reason why we use vasoconstrictors as well, nitroglycerine and vasopressin and somatostatin in particular, which are the vasoconstrictors, is because these will forcibly make the varices sort of collapse, and it will make it easier for the endoscopist to view. So you first thing when the patient comes is try to give them aggressive vasoconstrictor therapy, book them directly in for an emergency endoscopy and view and see what's happening, right? So if anybody has any more questions, please do type them in the chat and I will get to them, right? So we've completed the first part of our series more or less, which is liver portal hypertension. The next section is going to be hydatid cysts. Now, you will have access to this presentation, so I would take the time for you to read this. But in general, hydatid cysts are these cysts which are caused by Echinococcus granulosus. Now, Echinococcus, the species, it is found in dog feces mostly. So the typical patient who comes to you with this presentation would be a patient who's either a farmer or has exposure to dogs, a lot of them. And the thing is that they are exposed to dog feces in which this parasite exists, and it is consumed and enters more or less through the indirect fecal-oral route, or maybe just through fomites as well, right? Now, the issue here is that these patients don't have very specific symptoms. Most of the time, they are asymptomatic till the hydatid cyst reaches a very large size and it starts causing problems for the patient, right? And the most important problem is that this patient has non-specific abdominal pain. They have dyspepsia. They can have some vomiting. They can have retching as well. So they want to vomit, but they can't. Nothing's coming out. And hepatomegaly. Now, when you examine a patient, right, and you see hepatomegaly, all of your red flags should go up, because hepatomegaly means that there is a serious problem with the liver, right? Now, in the patient who has prior exposure, right, is a farmer or whatever their occupational status, and comes with these symptoms, you need to do something. You need to do an ultrasound. Now, the ultrasound is not very specific. What the ultrasound will do is that, yes, there is going to be enlargement and there's going to be a cyst or something, right? But if you might need to do further testing like CT, or CT is best, and sometimes you can do an ERCP too, but you may have to combine the ultrasound with a CT. In most cases, a CT is enough, because by the time these patients come in the developed world, they have a cyst that is manageable. They don't have very severe illness or very severe disease, right? And the thing with the CT is that you use the CT to try to understand the anatomy of the cyst so that you can plan out what you're going to do next, right? So the next treatment is that you also use serology to test for Echinococcus through the ELISA and immunoblood tests, which will show you an elevation of antibodies against the Echinococcus plus DNA fragments of Echinococcus, right? Now, in general, the hydatid cyst that is formed has two layers. It has an ectocyst and an endocyst, and the pericyst is formed by the host, right? So this is a question that is often asked with hydatid cyst. If you have this question, then 99 of the time, I've noticed that this question about how many layers are present within a cyst are asked, and you always say that the cyst itself has 2 layers, whereas the pericyst is caused by, it's a fibrotic change that is caused by the host. Now, if, for example, you have one situation here, which is in a lot of liver diseases, what happens is that you have you need to do something called an ERCP. Now, the basic thing with ERCP is if there is biliary involvement of some kind, right? So what does biliary involvement usually mean for a patient like this? What biliary involvement means is that this compression has caused some kind of changes in the biliary system, right? So maybe the cyst is so large that it is compressing on the common bile duct or whatever, right? So in that case, if you suspect that this patient also has some biliary involvement, in that case, you then need to do an ERCP. And what the ERCP does is the ERCP does 2 things. First is it's very good for diagnostics. You can see a direct image of what you're doing. And you can also make some therapeutic maneuver. You can do a sphincterotomy, you can remove something, you can take samples, everything, right? So an ERCP is very important. And in the next section, where we talk about gallbladder disease after a few slides, you will understand the importance of the ERCP, right? But in this case, most patients will have symptoms of obstructive jaundice. Now we'll be discussing obstructive jaundice, but in general, you need to know this part, which is these patients will have jaundice itself, which is icterus, gray stools, and dark urine. And if these are the constellation of symptoms, a patient has symptoms of obstructive jaundice, plus you suspect that they may have a cyst, then you do an ERCP and see if you can decompress the biliary tree. Now, here's the point with biliary involvement. There are 2 ways. You can do an ERCP, but the other thing is called percutaneous transhepatic cholangiography, which is you, instead of going via the nasogastric tube and going inside, you just go via the skin, go inside the liver, and then just visualize the gallbladder, and then you can use it to drain if you need to. Now, this requires some level of expertise, but it is something that you can do at the bedside. And we'll be discussing PTC in a lot more detail because it is very, very important in dealing with the consequences of biliary disease. And it is also something that you need to know very, very thoroughly if you're going to be working in the UK in the future, and if you're going to be working in the surgery department in any capacity. So with that said, we've just covered the hydatid disease in general, but the most important relevant fact is the management, as I've said here. And in management, you can do conservative management, which is what we do most of the time. Most of the time, there's no real need, unless there is like a lot of complications or whatever. There's no real need to do anything surgically. You give the patient some albendazole or albendazole, and that's enough. But in some cases, when the cyst is very large, you have 2 options. You can do surgical resection, which is, we do 2 things here. First is the radical resection, which is you resect the entire liver segment, right? That is involved. And you can also do something called a pericystectomy, in which you look at the cyst and you just excise around the cyst with keeping a margin, right? You take part of the cyst and you resect the tissue around it. That's all. And then we have a conservative option, which is something called PER, also called drainage and evacuation, in which you just drain the cyst if it's very close to the surface. And then you insert something called a solicidal agent, which is an agent that will destroy all the hydatid eggs inside. And then you just drain it out and wash it out as well. Now, the only way you can actually do conservative management is if the cyst is on the anterior aspect of the liver, where it is very close to access percutaneously, because this puncture aspiration system only works if you can access it through the needle, right? And if you can't, then there is no point. You can't do it. You'll need to do something else like a pericystectomy or go just manage conservative, right? This section here, pericystectomy and radical resection, these are called purely surgical management. And I have sometimes noticed the professor asking, what is the difference between a radical resection and a pericystectomy? The only difference is in the pericystectomy, you just cut the tissue immediately around the cyst and resect just that part. Whereas in a radical resection, you need to find out what the source is of which segment it is and remove the entire segment. And that is a very complex surgery, but it can be done, and it is reserved for patients where the cyst is very close to one of the veins. It's either very close to a central vein or it's very close to one of the feeding veins into the hepatic vein, right? Either where it's very close to the right and left hepatic vein. The reason why you need to do a full radical resection is because there is a very high risk of spillage. So if you try to just do a pericystectomy in these cases, when you're so close to the blood supply, you can end up causing the cyst to go into the blood circulation, and then you have widespread disease. And the disease most of the time goes either to the lungs or to the brain. So in that case, you have a bigger problem in your hands. So it is safer to do a resection. So let's take a look at this one. This is a very favorite question of the professors. And I would recommend that all of you take the time to actually study this because you will be asked questions on this. I can give you that as a guarantee, right? So when you are trying to classify the hydatid cyst, in general, like this, you'll have to read on your own. But in general, we just look at it. This is the this is the earliest stage that you can see that is clinically apparent with symptoms, right? Anything before this is most likely not going to be seen. We're very unspecific, But at this point, you can see that in the CL stage, this is the liver ultrasound. And in the ultrasound, you have a very clear picture of a cystic wall. And at this point, the disease is active. And the difference between an active and an inactive disease is that whatever is inside this, right, is capable of metastasizing to another side and causing a secondary infection there. So this requires you to have a very, very careful treatment management plan, right? Now, when you go more active, what actually happens is that this cyst ends up dividing and calcifying and forming small daughter cysts. So you'll have multiple of them present inside. And when you have multiple of them present inside, your biggest concern is that even if you try a pericystectomy, you have to be very good to understand both the anterior, posterior, superior, and lateral aspects of what is surrounding the cyst to try to take it out in total, right? Now, here there is something called hydatid sand. Now, hydatid sand is just the debris of all the inflammatory responses from the body, plus bits of the daughter cysts walls, because sometimes they may rupture, and bits of the parasite itself, right? Now, one question that is sometimes asked is, what causes the anaphylactic reaction in patients in whom the cyst has split open? And it's usually the contents of the hydatid sand. You see, the contents of the hydatid sand are, because they are all broken fragments, they contain these immunologically active fragments of the parasite, which can cause a severe anaphylactic shock. Now, this is not usually the case when you have daughter cysts, because once you have a presence of a cyst or multiple cysts, the cysts are walled off, right? And once they are walled off, they're separate from what is outside them. So the risk for anaphylactic shock or a very severe immune reaction is very, very low, as compared to when you have hydatid sand present or when you have debris from the cyst or a broken cyst inside. Which is why it is important that if you have a very large multi-loculated, multi-cyst hydatid cyst, then you should do a radical resection, simply because it is not really possible, or it's very difficult to only do a pericystectomy, because if you by mistake break the cyst wall, you can end up causing spillage everywhere. And the anaphylactic reaction would probably be the first thing that's going to happen. And the second is the very, very high risk of metastatic infection, right? So now that we've covered this part, if you guys have any questions, please type them in the chat and I'll get to them now. So I'm going to give you a minute to think about this. You can ask questions about the previous section as well as the current section right now. And I'm going to give you a minute while I drink some water. Okay, there is a question here. Will the pharmacological therapy influence the grading? I'm assuming this for portal hypertension. No, because if you look at the grading system takes into account things like bilirubin and albumin, and the prothrombin time, which are not really affected by vasoconstrictors. So the pharmacological therapy will not influence the grading. It's a very good question. Remember, the grading is done, like normally you do CTP grading just preoperatively. So by that time, the patient has already received some medication or whatever, but it's not going to influence it. Because remember, for any grading system, and if you want to check if the pharmacological therapy is going to affect said grading system, you have to think about what pharmacological therapy you're giving and what is the grading system based on, right? So for example, sometimes you do this thing called the CHAD2 score, right? Which is a cardiovascular disease risk score for operative patients. Now, the CHADVAS score is something I'll discuss much later, but right now in CHADVAS, what happens is that you look at the cardiovascular risk, right? So you look at whether the patient is taking any anticoagulants like rivaroxaban, apixaban, they're taking antiplatelets, because at that point, the pharmacological therapy does affect the grading in that system, right? But in portal hypertension, no, not really. In portal hypertension, we just look at what's on the scoring system: albumin, prothrombin, bilirubin levels, whether they have ascites, whether they have encephalopathy. That's about it. So I'm assuming that there are no further questions about the hydrated disease section. The next part is obstructive jaundice. Now, in obstructive jaundice, I have made a diagram in the corner which is going to accompany us over the course of gallbladder disease as well. In obstructive jaundice, remember, see, in jaundice in general, there is obstructive and non-obstructive jaundice, or you can look at jaundice from the perspective of whether it's pre-hepatic, hepatic, extrahepatic, right? Now, in surgery, what is most important for us, and especially at this stage, is obstructive jaundice. Now, obstructive jaundice is also called extrahepatic jaundice simply because the bile's outflow system is being affected by some way. So you see bile is formed here in the gallbladder. It comes out via this thing here called the cystic duct and goes into the common bile duct. And some of the bile comes from the right and left hepatic ducts as well. Now, when all of this bile comes together, this is already conjugated. Now, inside the liver, you have the conjugation system, right? So all of these obstructive jaundices, they occur because there is something that is compressing this outflow system of the bile. Now, it could be anything. It could be a tumor. It could just be cholecystitis. It could be cholelithiasis, which is a stone, or it could be a tumor, right? So if you have obstructive jaundice, how are you going to evaluate obstructive jaundice? So you know that a patient will have obstructive jaundice because their LFTs are most likely going to be normal, right? From a biochemical perspective, the LFTs most likely could be normal, right? But their conjugated bilirubin is going to be much, much higher than expected. They are also going to come with these very specific symptoms, right? The first is that they have icterus, they have pale gray stools and dark urine. And why is this? This is because conjugated bilirubin is not being absorbed by the stools, right? Because stools get their color from cercobilinogen, which is a converted form. And instead of going into the stools, as they should via this pathway here, they are going to be absorbed by the bloodstream and then get excreted in the urine. And once they get excreted in the urine, that brown color of the urine comes from the conjugated bile. This triad of obstructive jaundice is very important because you're going to be asked this multiple times, right? So icterus, which is jaundice itself, the yellowing of the skin, then pale gray stools and dark urine. And you have something called jaundice-induced pruritus. Now, jaundice-induced pruritus is when bile salts, which are a component of bile, accumulate underneath the skin. They are most likely subdermal. In some cases, they are subepidermal. But this patient will have a lot of itching. These things look a bit like bruises and rashes all over the body. And in addition to looking yellowish, with a yellowish tinge, they will complain that they have a lot of itching all over the body that just does not go away. And that is because they have jaundice-induced pruritus, right? Now, I've talked about the mechanism already. Liver functions, most of the cases, it's normal, but in some cases that there is cirrhosis or maybe Budd-Chiari syndrome or something, then in that case, there may be some alteration in the LFTs. Now, your main concern with obstructive jaundice, once you establish that a patient has these symptoms and their bilirubin is really high, your main aim is to localize the jaundice and see where the obstruction is, right? So we divide, in general, the location of the obstruction for hepatic jaundice or for obstructive jaundice in two ways. You have intrahepatic, which is cirrhosis, and extrahepatic. So extrahepatic is anything that comes outside of the liver. So that includes the entire biliary tree. So you can have an obstruction in the right and left hepatic ducts. You can have an obstruction in the common hepatic duct, or you can have a obstruction anywhere along the cystic duct or the common bile duct. In some cases, there is an obstruction in the ampulla of Waiter, right? And this obstruction can be caused due to three things. One is a periampullary tumor. One is the mass of a pancreatic tumor pressing against, right? And the third is if there is a stone. Like sometimes, very rarely, stones get impacted in the sphincter of Oddi or at the periampullary region. Here, why we are going to be focusing on this section a little bit is because this is what most of gallbladder disease is going to be about, especially when it pertains to you guys and your exams. So you have an obstruction in the neck of the gallbladder. So this is the neck here. And this is called Mirizzi's syndrome. So what happens is that you normally have gallstones, which in and of themselves don't cause any symptoms or anything. Is normally when the gallstone moves and migrates from the gallbladder into the neck or down the cystic duct, you will have symptoms. So your job is to try to localize where the obstruction actually is. If there is some kind of intrahepatic cause, there's most likely cirrhosis, right? But this is cirrhosis, and that may also cause increased LFT. So that's when you should think about whether this patient might have cirrhosis or not. But in extrahepatic causes, you'll have these. And these extrahepatic causes, they form the basis of gallbladder disease, which we'll be covering next. Now, in order to manage it, most of the time, you just have to manage the underlying etiology of obstructive jaundice. If the patient has a stone, then try to remove the stone. If there's excessive bile, then you need to, and the patient is crashing and they're not good for surgery, then you just do a PTC, percutaneous transhepatic cholangiography, and then you just drain out the bile directly, right? In some cases, you can also do endoscopic biliary drainage, in which you do a nasobiliary tube insertion, and then you slowly drain out the tube, drain out the bile, or you can insert something called a T-tube, which is sort of like a T-shaped thing, which will help you to drain all of the bile that is present, right? So this is in general for obstructive jaundice. Now, you're going to go into the gallbladder disease part, but if you have any questions, please write them in the chat and I'll try to get to them as quickly as possible. I can see there is a question up here. Would unconjugated bilirubin, like I'm assuming unconjugated bilirubin. No, unconjugated bilirubin will not be high in obstructive disease. See, unconjugated bilirubin is high when the blood, when there is a lot of destruction of unconjugated bilirubin and it is not being conjugated in the liver. So you need to think whether there is a liver problem or not, or whether there is something called hemophilia where there is destruction of the red blood cells in a manner that is much larger than is normally expected. That is why the unconjugated bilirubin is high, right? So when you look at the balance of bilirubin itself, right? When you look at the balance of bilirubin, you have unconjugated bilirubin and conjugated bilirubin. Unconjugated bilirubin, comes all the way from the spleen and the blood, and it enters inside the liver. And inside the liver, it undergoes conjugation. And this conjugation process is a rate-limiting process using one enzyme called UBT. And what this does is it converts unconjugated bilirubin to conjugated bilirubin, right? So what happens is that if, for example, your conjugated bilirubins are high, that means that there's no extra amount of UDT that you can have. In very rare syndromes like Roberts syndrome or something, you can have an overexpression of some types of receptors, but that isn't the main cause of the disease. Most of the time, or basically in 100% of the time, if you have a lot of conjugated bilirubin, that's because the bilirubin is not being drained into the intestine where it needs to go. It is instead being constantly blocked off here in the gallbladder, or it's somewhere here in the biliary tree. In unconjugated bilirubin, you can think of multiple different things. You can think that maybe the patient's hepatocytes are not functioning. So a lot of unconjugated bilirubin is entering inside, but there's no transformation, nothing. So they're not getting converted to bilirubin at all because the hepatocytes are just not functioning, right? So that is the main difference. Now, for a full understanding of jaundice, I think we can discuss it the next time because we will be studying some of the stomach and colorectal cancers. So maybe if you have some time, I'll dedicate some time to just understanding whether jaundice is, hepatic, post-hepatic, or extrahepatic, but that's for the next time. But for now, just remember that unconjugated bilirubin enters inside the liver, where it gets converted to conjugated bilirubin. And if there is extra amounts of conjugated bilirubin, that means it's just not draining from the liver, and it is not going from the liver to the intestines where it's supposed to go, right? So with that said, if there are no more questions, I'm going to go ahead with the next part, which is called gallbladder disease. Now, gallbladder disease is unfairly, I think it is considered very complex for a lot of students. It's not that complex. And hopefully today we can clear up some matters for you. So I want all of you to first take a look at this diagram in the corner. It's not my best work, but I didn't want to be copyright struck, so here it is. So in this case, you can see that the gallbladder has these three parts. There's a body, there's a fundus, there is a neck. And in the neck, you have this outpouching called Hartmann's pouch, right? And then this leads into something called the cystic duct, right? And the cystic duct forms with the common hepatic artery, the common hepatic duct, the common bile duct. And the bile duct takes some input from the pancreatic duct, and they all open into the ampulovator, from where they go into the duodenum. This is the basic structure, right? Now, when you look at all of these diseases, cholecystitis, cholelithiasis, choledocholithiasis, and cholangitis, they just refer to the disease process at different levels of the biliary tree. So cholecystitis is actually the inflammation of the gallbladder itself, right? Choledocholithiasis is the inflammation of the common bile duct, right? Cholangitis is basically an inflammation of anywhere up and down this tree. Whereas cholelithiasis is a condition where you just have the formation of gallstones. Now, I want all of you to, again, just take a look at this chart here and you'll understand what cholecystitis is versus cholelithiasis. Now, cholelithiasis is just the formation of gallstones. Most cases, they're asymptomatic, there's nothing much. But when there are symptoms, you have this very specific symptom called gallstone colic, which means the patient has eaten something, and after a couple of hours, they have this sudden strong pain that makes them almost double over, right? And now this happens because after you eat any food, and it enters into the gallbladder, into the duodenum where it's supposed to, there is a hormone called cholecystokinin. Now, cholecystokinin acts directly on the walls of the gallbladder to stimulate the release of bile, right? Now, at this stage, what happens is that the patient eats something, food is going as it's supposed to in the duodenum, and there's a sudden contracture of the gallbladder, and this sudden contracture causes the nerve endings to press against the stones, and that is what causes the pain in cholelithiasis. Now, for those kinds of patients where the stones are just in the fundus itself, they don't have cholecystitis, which is, complete inflammation of the gallbladder. In that case, you just do conservative management. You make sure that those patients don't eat fatty food. They try to do good diet, exercise, and yearly screening, using just ultrasound. But all of these diseases that you see, choledocholithiasis, cholecystitis, and cholangitis, they are caused by cholelithiasis. So these patients will have cholelithiasis at first, and the migration of that stone is what causes most of these diseases. Now, yes, of course, you can have acalculous cholecystitis, but that is a very rare case. It comes in less than 5% of the patients, and it's mostly due to an infection of some kind, right? Same with cholangitis. It is caused by the infection of the biliary tree, right? But the underlying cause could always be gallstones. And if there are no gallstones, then you have some other very severe sickness, which is causing a concurrent infection in the biliary tree as well. And sometimes you can have this secondary to some kinds of rare cancers as well. So cholangiocarcinoma can also sometimes present first with cholangitis, and then it turns into cholangiocarcinoma. But in this case, I want you all to remember that the only difference between these diseases is the location of where the stone is causing the obstruction. So if the stone is causing an obstruction somewhere here, in the common bile duct, or like in the periampullary region or the ampulovator, you will call this choledocholithiasis. If it's up here in the cystic duct, right, it is only going to cause inflammation of the gallbladder, so it is acute cholecystitis. And if the stone is present very specifically in something called the Hartmann's pouch, which is this one, this is called Merytze's syndrome. And Merytze's syndrome is rare. I mean, you wouldn't say rare, but it is not unheard of. And it is important for you to know because this is sometimes the first symptom of a patient with cholelithiasis at all. It's that they have these unspecified pains for a couple of years now, and suddenly they have this really severe infection. And then when you turn to see, they have cholecystitis, but they have it in the Hartmann's pouch, right? And then you call that Merytze's syndrome. Okay, so now we're just going to go to the next part. In this case, I want you to draw your attention to cholangitis. So cholangitis is the infection of the biliary tree, right? I'm sorry. And it presents with something called Charcot's triad. Now, Charcot's triad is jaundice, fever, right upper quadrant pain. Now, I want all of you to focus on what Charcot's triad is. Fever, jaundice, right upper quadrant pain. This is always asked of you in the exam anytime. It is one of the questions that is seen as a standard. What is Charcot's triad and what is Reynolds pentad? So if you ever hear the word Charcot's triad, right upper quadrant pain, jaundice, and fever, think cholangitis immediately, right? Think cholangitis and then you can rule it out, right? So with that said, let's go on to the next slide where we look at the interesting imaging options we've got. Now, if any of you is going to be working in the UK or wherever, or even here, remember that the first step is always to do a simple ultrasound. When you do a simple ultrasound, you diagnose acute cholecystitis based on the ultrasound, because in the ultrasound, the wall of the gallbladder is going to be thickened. And if it is thickened, it is cholecystitis. As simple and direct as that. The other thing is that you can also do a CT of the abdomen if you suspect that this patient may have either a complicated stones or multiple stones, right? Or you want to actually look at the biliary tree, because when you look at the biliary tree, this is a typical image, right? But in a lot of patients, you'll have variant anatomy. And what variant anatomy looks like is you may sometimes have the common bile duct just bypass the ampulla or waiter. In some patients, the pancreatic duct is separate from the common bile duct. In some patients, they have this gallbladder has two outpouchings, like two ducts coming out instead of one. So in order to better understand that, you do a CT abdomen. Now, when we go down here, we have ERCP and MRCP. So ERCP is endoscopic retrograde cholangiopancreatography, right? And this thing is this image here. And it is a very standard in a lot of pancreas, gallbladder, duodenal cases, right? Because this thing, not only does it allow you to visualize what's going on directly through the camera, but it also allows you to have access to instruments. So you can move the sphincter, you can do a sphincterotomy, directly grab a stone, take it out, right? You can even go up the biliary tree and manually retrieve a stone from there, right? You can decompress the bile duct or the gallbladder using just the ERCP. Now, the difference between ERCP and MRCP is MRCP is an imaging modality only. That is magnetic resonance cholangiopancreatography. And it is a very good imaging source when you can't delineate the extent of the disease on a CT. Because sometimes the CT is not very specific. Sometimes there can be shadows, or the radiologist is not convinced. Then in that case, they can do an MRCP. Now you have two things here. The first is the PTC. So the PTC, like I said before, is percutaneous transhepatic cholangiography, in which you insert a dye by going through the skin percutaneously, go past the liver, and then you will access the gallbladder, and then you inject dye into the gallbladder, and then you can visualize the gallbladder and see whether there is anything, there is some kind of material present in the gallbladder already, or the shape of the gallbladder, and see if there is some outflow. You can also use this opportunity to aspirate inflammatory contents. Now, the issue here is that we use something called a HIDA scan. You will see the word HIDA scan a lot, especially if you are going to give more advanced questions in the MRCS, or if you want a 6, mention the HIDA scan. So what the HIDA scan does is you take a radioisotope level labeled derivative of immunodiacetic acid, right? And you inject it into the patient and wait for 45 minutes. Now, within 45 minutes, this substance is going to be taken up in the gallbladder. And you can see these very small images. Unfortunately, I didn't have a very large image. But what it does is that it allows you to visualize the contraction of the gallbladder. So in order to see whether what you're doing essentially is you're tagging the bile's formation. So that bile forms inside the liver, right? Goes into the gallbladder and the cystic duct. And you can see it sort of not in live motion, but you take pictures every couple of minutes. And you can actually see the contraction of the gallbladder and see if everything is going okay or not. And then this image, the very small one, but if you open it in your computers later, you'll see it's decently good. You don't really have any kind of obstructions. And you can see the bile essentially entering the duodenum. Now, if there is any delay, or you can't visualize this material entering the gallbladder, in that case, you can think that there's a massive, massive obstruction somewhere, and you need to fix it. For example, if you see that it is present in the gallbladder and it's not moving anywhere and hasn't gone to the duodenum by 90 minutes, then that means there's a severe obstruction. You need to operate, right? So this is the thing for the HIDA scan. And the HIDA scan is also used for a lot of other things, whether the sphincter of Oddi is working properly, or whether there's a biliary leak, right? Or if there is the patency of the biliary stent is working or not. So one of the best things that you're going to do is actually to drain the bile, right? So as we discussed before, you can put in a stent that goes via inside the bile duct and drains all of the bile, directly into the duodenum or into the common bile duct or in the periampullary region, right? Now, if you want to know if it's working, you use the HIDA scan. That's it. You use the HIDA scan, you'll have a very good image and you'll see where exactly the bile is going by itself, because you have tagged the bile, right from formation to drainage. So now with that said, let's go to the operative management, right? Now, most of these patients who come to you with cholecystitis, they need to be operated on within 72 hours. If they're not going to be operated on within the first 72 hours, then you need to wait and watch. But you'll have to do a cholecystectomy anyways, but you wait after 2 weeks for that. So if on acute presentation, this patient has just come to you and it's not been more than 48 hours, then you can consider cholecystectomy. If it has been longer than 72 hours, then definitely don't do it, right? You wait for 2 weeks and then you do the cholecystectomy. Now, in the cholecystectomy as well, the cholecystectomy essentially is the removal of the gallbladder. And you can do two approaches. The first approach is that you do an open one in which you just open up the full gallbladder and remove open up the abdomen, go into the gallbladder, remove it, and that's it. The point is that open cholecystectomies are very rare. Even at our department, we usually do a laparoscopic cholecystectomy, and laparoscopic approach is better simply because you have a lower risk of bile leaks, you have a lower risk of transecting and making bile duct injuries. And the most important thing is that this is minimally invasive and safe for the patient, right? So in this case, when you want to know about laparoscopic cholecystectomy, you just need to know the port placement. So we have essentially 3 ports. One is the umbilical port, which is the camera port. You have the subxiphoid port, which is used for the right arm. And this is the left one, which is just a subcostal. And this allows you to grasp and use the 2 instruments. And sometimes you use a 4th port here, which is usually just below the right subcostal port. And this is used for retrieval of the gallbladder. So you just put it in a bag and this thing holds the bag and pulls it out. So when you're describing the laparoscopic technique, you need to actually look at what the patient's position is, port placements, and the exposure of the Callas triangle. Now, let's talk about what the Callas triangle actually is. So let's go back here for one slide, and you will see this is the Callas triangle. The Callas triangle is bounded superiorly by the cystic artery, inferiorly by the cystic duct, and it meets at the common hepatic duct. Now, a lot of books have this wrong. They say that the Callas triangle is bounded superiorly by the inferior border of the liver. If you say that to the professor, he's going to mark you wrong, and he does ask what the Callas triangle is. I mean, I was asked this question myself. So the Callas triangle is this one, is that it is bounded inferiorly by the cystic duct, medially by the common hepatic duct, and superiorly by the cystic artery. Now, why is this important? This is important because in a laparoscopic cholecystectomy, the first thing you're going to do is to try to ligate the cystic artery. So you put a clip here. And if you understand where the Callas triangle is, you dissect the Callas triangle, which means essentially you separate it out. And then you put one clip here in the cystic artery, one clip at the cystic duct, and then you remove the gallbladder, right? Now, there are some complications, of course, of cholecystectomy. The biggest complication is going to be cholangitis, and you can have bile duct injuries as well. Now, there's a classification system I've made. You need to request it personally, but study the Strasbourg classification of bile duct injuries. They are very important, and they will sometimes be asked in the questions asked by the professor, right? So with that said, we've just completed the gallbladder section. In another 15-20 minutes, I'm going to try to finish pancreas for you. If you have any questions, you know the drill by now. Type them in the chat, and I will get to them immediately, right? Okay, so we have some questions in the chat. I will address them now. So is the Hartmann's pouch present if the patient never had cholelithiasis? Yes. So the Hartmann's pouch is an anatomical variant, and it's seen in a lot of patients, I think upwards of 70 to 80%. And someone asks if in the 5th year surgery exam were you expected to know the details and steps about surgeries? Yes, in the practical part, yeah, they would ask you what would you do next, what's the general operative technique, what was done, what was not done. You don't need to go it and you don't need to go in the complete detail, but you need to know, okay, what is a cholecystectomy? What are you removing in a cholecystectomy? What are the options? That sort of thing you need to know. You don't need to know the full complete detail. And to be honest, this is not the full detail as well, because the real detail of the cholecystectomy is really long. And for your level, you guys don't need to know it as of now. For the exams, you have to know what the cholecystectomy is. And in general, what are you removing? What are your contraindications? That's it. Another question has come here as well. Isn't Carrot's triangle used to identify? Yeah, you identify the Carrot's triangle by knowing where the cystic artery is. Look, for localizing the cystic artery, the most important landmark that we sometimes use, at least in my experience, is you just look for the cystic duct and look at the place where the cystic duct and the cystic artery come close to each other. At the place where they come close to each other, that's where you know that is the upper and lower limit of the Carrot's triangle. So the Carrot's triangle is just a space between these two things. So I hope that makes it clear. Now, does anybody else have any further questions about gallbladder disease? Okay, so there is a further question by someone here. So, look, you can see the cystic artery is not found within the callus triangle. Cystic artery forms the outer boundary of the callus triangle. The cystic artery is part of something called the cystohepatic triangle. Now, the point is that in some of the presentations that I've seen, you have two versions of the same presentation. One that confuses you by saying that, oh, the cystic artery is found within the callus triangle. Unfortunately, that is wrong. If you look at any of the bigger textbooks, Gray's, Saveston, Schwartz, the Michigan Manual of Surgery, or the Boston General Hospital's manual, and including like the more advanced textbooks, right? There is okay. Yeah, I will read out the questions. Like normally, look, when you look at the callus triangle, you need to know that the callus triangle is the upper limit is the cystic artery. Like cystic artery is contained within something called the cystohepatic triangle, of which the callus triangle is a part. And if anybody tries to debate you on this, just show them the textbooks. That's like this is quoted in Gray's as well, like Gray's Surgical Anatomy, right? Yeah, there's a thing that if I can read out the questions because we can't see them. Yeah, sure. Okay, I'll do that from the next time. And if anybody has any more questions, now would be the time before I go into pancreas. And I promise, I know that people's attention span is going to be going lower and lower from the 1 hour point, but let me please hold your attention for just 25 minutes more. That's all. Okay, so I don't think there are any more questions right now. So let's go into pancreas, right? And so in the pancreas, look, in the pancreas, we're going to just discuss acute pancreatitis, chronic pancreatitis, the pancreatic cancers, where they are located, right? And how to do the Whipple's procedure. Those are the most important things, right? So the most important thing about acute pancreatitis is, remember, when you're trying to make a diagnosis of acute pancreatitis, right? The patient has left-sided pain, right? They are going to, they may have nausea and vomiting, right? And the thing is that the left-sided pain is not always the case. You can have epigastric pain, which is more important, which is more towards the center, right? So when you think that a patient has acute pancreatitis, the first thing you should do is think, has the patient consumed alcohol before, or are they taking certain types of drugs? Do they have hypertension or whatever, right? Because when we look at the causes, which we'll go in a minute, you will see that there are some drugs that cause acute pancreatitis as well. So you have this thing called the diagnostic philosophy. Now, look, the diagnostic philosophy sounds like a very big term, but it's not. It's just the way you think about coming to a diagnosis. So when you think that a patient has acute pancreatitis, the first thing you need to do is ask what is causing the acute pancreatitis, because you are going to try to treat the etiology. So the same thing you do with cholecystitis as well. You treat the underlying problem. With mechanical obstruction, you look at where the obstruction is, treat that. Same thing goes in acute pancreatitis as well. What is causing the acute pancreatitis now, right? Second is, am I correct in thinking this is acute pancreatitis and not something else? Is this a splenic artery problem? Is this a spleen problem? Is this an infection of the liver? Am I mistaking the symptoms of acute pancreatitis for very rare causes of liver obstruction, gallbladder obstruction, right? Now, the most important is severity. Now, there are three different scores for severity, but for us, most important is the Atlanta classification. When you're treating acute pancreatitis, you need to do two things. The first thing is, if the patient has consumed a lot of alcohol, then in that case, you have to just let them be, give them pain medication, and let them rest for a few days, right? 1 or 2 days. But if the patient has come to you with an infective cause, they have some other really severe disease, right? The issue with severity is that what severity allows you to do is to predict whether this patient will need to be sent to the high dependency or the ICU unit, right? And they sometimes do need to be sent to those units simply because they show symptoms of something called SIRS. So SIRS is severe inflammatory response syndrome, and this is mostly characterized by hypertension, or maybe fever, and low or very high white blood cell count, right? And in this, what happens with SIRS is that you may have end organ damage. That means their liver or kidneys are shutting down, right? We've got a lot of participants coming in. Okay, I'm sorry, but okay. So what you are doing, your basic idea with acute pancreatitis is that, okay, if you have a patient with acute pancreatitis, and in your essays, first thing is write down the symptoms. Second, write the causes, which is given up here. And the easiest way to remember the causes is generally I get smashed, which is I is iatrogenic, which is, sometimes you can have acute pancreatitis after ERCP, or you can have it due to an infection like mumps or Coxsackie virus. G is for gallstones, because remember, gallstones cause a lot of diseases. They're very, very problematic when they start causing symptoms. And then, of course, alcoholism, abdominal trauma, ampullary tumors, and then drugs. Now, from these drugs, we are sometimes going to be asked, and I was as well, about which drug causes, can you name at least 2 drugs that cause acute pancreatitis? So remember, corticosteroid use, especially in patients who are taking corticosteroid therapy for any dermatological conditions, or they're taking it if they have asthma. Sometimes that can cause acute pancreatitis too. And estrogens. So estrogens are for women who are taking oral contraceptives. This is sometimes a risk. So what will happen in these patients, and this is an important bit because I have also seen a patient like this. She was taking oral contraceptive pills just for 3 months, and then she suddenly presented to the department with severe abdominal pain. And she thought at first that it was maybe her period coming back, right? But the issue is that the characteristic of the pain was very different. Now, at another talk, I will talk about pain syndromes in women because they're different from pain syndromes in men sometimes. And the primary thing that we were concerned about was whether she had an ectopic pregnancy, right? Which is when the implantation occurs at an area outside of the uterus. But when she said that she'd been taking oral contraceptives and she had this pain that is uncharacteristic, but there's no guarding per se, then we understood that this is probably acute pancreatitis, and that was confirmed when we did a CT and a serum amylase level test, and she was clear for everything else. So remember that the drug-induced acute pancreatitis is a very important women's health concern, and it is something that you need to be watchful for. That alongside myocardial infarction in women, because it presents a little bit differently than it does in men. So that aside, you also have the rarest cause, and this is a fun cause if you are going to go to the US, right, is scorpion bites. So normally the question will be, a man is walking around in the Nevada desert, he was hiking or whatever, and he has come to you with severe abdominal pain after he felt something touch his feet. That is because of a scorpion bite. Now, this kind of thing is not very common. I have personally not seen it, but my dad, who happens to be a general surgeon, he has seen a scorpion bite-induced acute pancreatitis. And the issue is that if you are living in India, for example, not in the whole of the country, but if you're living in Rajasthan or in the western parts of the country, then yes, you need to be aware of this fact that, okay, some scorpions can cause acute pancreatitis as well. It is the rarest cause, right? So with that said, we've gone through the basic idea of what acute pancreatitis is. But remember that the surgical management of acute pancreatitis is reserved only for severe cases. So you look at severe cases when the patient is either entering SIRS, or they have very low blood count or very high blood count as well. And they may have some other systemic syndromes like a severe fever, or the patient just looks unwell, just can't walk, can't do anything, right? In that case, just suspect that they have at least moderate moderately severe pancreatitis. And in this case, you just do one thing. In addition to giving them analgesics and antiemetics, you start giving them antibiotics. Now, you can give them ERCP too, because you need to find out what is causing the acute pancreatitis, right? And in some cases, when the patient is really sick, the reason why they have acute pancreatitis is because they have splenic, they may have a like trauma to the spleen, for example, or some other blunt abdominal trauma. For example, it is also possible to have acute pancreatitis just by falling on the floor if you are a chronic alcohol abuser, right? And it sounds impossible, but yes, I have seen a patient who had severe acute pancreatitis simply because he was a regular use of alcohol, was a chronic alcoholic for almost 20-25 years, and he was drinking on a Friday night or something, and he just fell down the stairs. And then he came with severe pancreatitis simply because just that force of him falling down ended up causing some kind of blunt intra-abdominal trauma. He also had splenic trauma as well, and that caused a concurrent acute pancreatitis. So he had acute pancreatitis due to blunt abdominal trauma. And the second thing he had was a splenic trauma as well, with subcapsular bleeding, right? And the thing is that these causes are not rare per se. They may be rare in some countries, but we have seen cases like this, especially at the hospital here, right? Now, you give them some kind of antibiotics, imipenem, or you can give them ciprofloxacin and metronidazole. Here in our department, we give them ciprofloxacin and metronidazole. And you have to give them supplemental oxygen, aggressive fluid resuscitation. Now, what I mean by aggressive fluid resuscitation is that you have to try to get their urine output much higher than it is. So it's roughly around 15 milliliters per kg per hour. That's what aggressive fluid monitoring means. And you're going to do some monitoring itself. So you need to constantly monitor their urine output, blood pressure, blood gases, right? And you can also insert an NG tube and make the patient totally parentally, to give them total parenteral nutrition until you find what has caused it and if you can treat it, right? Now, the diagnostic workup for any patient who does not really come with very severe pancreatitis or just comes with pancreatitis and you don't know what its staging is, if you want to stage the patient, use a CT first, and then you can use an ultrasound. Because see, in acute pancreatitis, the ultrasound is not that helpful. It's just not going to do much. So it's always better to do the CT first, right? And then you can use ERCP. And the most important biochemical test is pancreatic amylase, which is going to be 3 times the norm, right? And the most important other pancreatic test is going to be pancreatic lipase. So you use pancreatic lipase when the patient has come after 72 hours. So for example, the patient has been in severe pain for a couple of days and then somehow he manages to make it to the hospital and then he's come to you for consultation. Then the thing is that the value of the pancreatic amylase statistically is not that good. You should still do it, but you should rely more on the pancreatic lipase level tests, right? So with that said, we've more or less done with acute pancreatitis. Chronic pancreatitis is pretty much simpler than acute pancreatitis. See, chronic pancreatitis occurs when there's an underlying pancreatic pathology, which is mostly the case in patients who have very severe or very long-standing pancreatic disease because of excessive alcohol abuse or whatever, right? So they've been abusing alcohol for a long time. They have had a lot of different infections. And sometimes they have something called systemic lupus. So one of the symptoms of systemic lupus is chronic pancreatitis, right? And you can see this here as well. You have acute autoimmune conditions written here. So if your question is chronic pancreatitis, right, what would you do? The thing is that try to define it this way. The chronic inflammation of the pancreas that leads to fibrotic changes. See, the mentioning of the word fibrotic changes is important because fibrotic changes are what reduce the pancreatic function as well, right? And most of the time you have therapeutic pain, they come to the department with chronic pancreatitis because most of the time you don't really have any symptoms of chronic pancreatitis. You may develop diabetes that is managed by the endocrinologist, so that's fine. But when they do come to the hospital, is because they have something called an acute pancreatitic flare-up, which looks very similar to acute pancreatitis, and you manage it more or less similar. In this case, if you know that the patient already has chronic pancreatitis and they're just coming with a flare-up, your thing is to just do a CBC and a basic metabolic panel, and just look at the LFTs to see if that it is just chronic pancreatitis and not, a cancer of the pancreas in any way or a distal metastasis or whatever. And you just do an amylase and lipid panel so that you can make decisions of what you're going to do next. And the thing is that you do surgical management only if there are complications. So, for example, if there is the pancreatitis is causing gallstone, like it's causing bile duct obstruction, for example, right? Sometimes it can cause sometimes there can be pancreatic rupture, there can be pancreatic fibrosis, there can be pancreatic cysts that are secondary to pancreatitis. So for those cases, you just do a surgical management, and the management aim essentially is to try to either resect the tumor if there is one, or drain out the cyst if there is one, or if there is some kind of damage. Generally, you can't repair the pancreas or the spleen. They are just too delicate, right? And it requires you to have the specialty of an HPB surgeon to do it. So in general, your surgical management is only for managing the complications of chronic pancreatitis, which could be anything from malignancy to tumors or whatever. Now, there is one theory which says that chronic pancreatitis is just untreated acute pancreatitis, or it is basically a more advanced form of acute pancreatitis. So some pathologists believe that if you let a patient with acute pancreatitis go and don't do anything whatsoever with no supportive care, whatever, multiple recurring episodes of acute pancreatitis lead to a chronic pancreatic state in which the acute pancreatitis ends up just becoming a flare-up of the chronic pancreatitis, right? And see, one of the things is that these symptoms are steatorrhea and weight loss. Now, they don't have weight loss because of malignancy. They have weight loss because they can't eat or digest anything. Anytime they eat, they're going to have postprandial pain. They eat anything, they have pain. They eat anything, they have pain. And also because of fibrotic changes, the level of pancreatic lipase goes down. And that is why you have a lot of steatorrhea. So their stool is very smelly, and it has, it's foul smelling, and it looks a lot like mucus, but it is actually a lot of lipids and fat that is coming in the stool, right? So in this case, also remember that you have to rule out malignancy whenever you can. Look for the complications. If there are no complications, just pain. And if most of the time, if they're using alcohol or something, they need to reduce alcohol and change their diets. Like whichever diet they're on, they need to change it. So now we're done with chronic pancreatitis. Let's just look at pancreatic cancer in general. And see, in pancreatic cancer, most pancreatic cancers are going to come to you when they have no other treatment options at all. There is literally not much you can do, right? And the thing is that you classify pancreatic cancer into two types based on where they are. So head, neck, body, and tail, right? And the thing is that you can do certain types of procedures as long as the cancer is resectable. And you define a resectable cancer as whether it is T1 or T2. Anything beyond that, and it's considered unresectable, or if there are lymph node metastases. Now, you have ampullary pancreatic tumors and neuroendocrine tumors. In this, you have non-functioning and functioning type. Most of the time, pancreatic cancers will come with symptoms of diabetes, which is called pancreatogenic diabetes. And they can come with weight loss and abdominal pain, and in some cases, jaundice, because the cancer or the tumor mass is compressing on the bile duct. The only way to treat it is that, you have a lot of surgical management options. I'm not going to go through all of them for the sake of time, but the basic one is this one. This is an actual question that you will have in the topic for your exam, and it's called surgical management of the pancreatic cancer through localizations. So that means essentially that if the cancer is present in the head, you do Whipple's pancreatectomy, which is you remove part of the pancreas, you remove the part of the gallbladder, gall duct, and you also remove part of the duodenum with it, and you resect everything and make a different arrangement, which is present on the next slide, I think, yeah. If the cancer is present on the neck, like neck or the body, like essentially the neck, which is this part and this part, in that case, you do a distal pancreatectomy in which you cut off this part altogether and just leave the head as is. Now, if you have a tumor in the body and the tail, you do something called a distal pancreatectomy, which is just a removal of the pancreas, right? And you can combine this with a splenectomy if you need to, if there is a massive splenomegaly, or you can do a regional lymphatic adenectomy as well. That is up to you as a surgeon. Most common question here is what chemotherapy you can use. That is gemcitabine and 5-fluorouracil. That's it. Now, the same thing happens with neuroendocrine tumors, right? There are lots of them, right? But remember that they are based on the type of cells that they are found in. So, for example, you have insulinomas, which are found in beta cells. Gastrinomas are found in G cells, and then VIPomas and glucanomas and stomatomas. Most of these patients, you will see that they are producing an excess amount of the hormone that they are responsible for. And sometimes the most important one is the insulinoma. And in insulinoma, what happens is that this patient is otherwise normal, but suddenly, for example, they'll have sweating and they'll just they'll start swearing and cursing or behaving very erratically. That's because they have a very symptomatic rapid hypoglycemia because of excessive amounts of insulin dumping into the body. For these also, you do the same thing. You just see where it is at, and either you can give them chemotherapy or perform the Whipple's procedure. So the Whipple procedure is going to be this one. In Whipple's, what happens is that I've put out the steps here because you will be asked about the Whipple's procedure itself to just study this part. What happens in Whipple's is that we resect part of the head, we resect the head of the pancreas, we remove the gallbladder, gall duct, the common bile duct, and we remove the C arm of the duodenum, or the first two-thirds, roughly speaking. We remove it all together because they share the same common blood supply as the gastroduodenal, pancreatoduodenal artery. And once you remove this, what happens is that you basically form an anastomosis between this limb of the duodenum and connect it through an end-to-end anastomosis to the pancreatic head. And then you take the gallbladders, like whatever's remaining of, most likely this is going to be the common hepatic duct, and you do an end-to-side anastomosis and connect it to a duodenum. And you connect the stomach through an end-to-side anastomosis as well, and you have this shape essentially, right? So if you're going to be asked to define the Whipple's procedure, just say that it is a pancreatoduodenectomy in which the duodenum is removed, head of the pancreas is removed, and so is the gallbladder. And then you have anastomosis of this type to form a sort of bowel continuity, so that you can have bowel continuity for these patients, right? And most of the time, the survival rate is barely a third, I think, if that. So with that said, I am going to give you guys 5 more minutes for any more questions that you have. I'm also going to put the link of the feed